Hi, welcome to Case of the Day, and we've made it to the 70th case. I can't believe this. But today's is an interesting topic, the power of a follow up strategy, learning about titin, genetic dilated cardiomyopathy. So, this was a 55-year-old with a 12 years history of having a dilated cardiomyopathy and a family history of two, three members having died at the age of 40 due to cardiac causes. And this was an MR done last year in July. And you can see that there is a mildly dilated cardiomyopathy. There's a lot of systolic dysfunction. The septum is most involved, lateral wall is the least involved. The T1 was elevated predominantly in the inferoseptal segment. T2 and STIR are normal. And there is abnormal mid-myocardial enhancement predominantly in the septum, but if you look at it, it's actually ring-like because you can see it at the same level in the septum and lateral wall and anterior and inferior walls. So septum being the most severely involved, but a ring-like pattern. And when you see a ring-like, and these are the findings, there's a dilated cardiomyopathy and a ring-like pattern of enhancement. And these are the different causes of ring-like enhancement. I'd done a case at MRIcardiac.com, I think about a year and a half or so ago, and I'd looked at different causes. But the vast majority of patients who have ring-like enhancement have a genetic cardiomyopathy, and there are different forms of genetic cardiomyopathy. So we suggested that this is likely a genetic cardiomyopathy, and we said, please get a genetic study done. Now, these take time, and so I had actually kept a reminder for a follow up a year later. I mean, I have a kind of a system where it gets triggered, and so it came up about 3 or 4 days ago. And then I asked one of my medical officers to call for a follow up. And the patient was very prompt, and they gave the genetic report, which then came to me, and I saw it this morning. And it is a titin positive, TTN positive, autosomal dominant inheritance, heterozygous dilated cardiomyopathy, or titin is the cause here. And in fact, titin is the commonest genetic cause of genetic dilated cardiomyopathy. These are the others that are listed here. We've seen one case of MYBPC3, a couple of laminopathies, we've seen a Duchenne, Becker, etc. And there are now papers, again, because this is a hot topic in cardiac MR, where people have tried to differentiate among the various types of genetic cardiomyopathy. But that's not the point of today's video. It is the power and value of a structured follow up strategy that allows us to keep learning and understanding. And way back as a resident, I was taught by Dr. Ravi Ramakantan and my father, who's a radiologist, and both of whom are still around, that you just need to keep following up. Sometimes the follow up is immediate, like in a day or two. When I do biopsies, I have records of all my biopsies done over the last 12 or 13 years. I mean, I've lost the ones before 2012. And every case is documented, and so you can learn from all of these things, and that's the whole point. I mean, how else do we learn, right? So there must be some form of getting follow up in our practices, and half the times the patients will be lost, or may not want to give us follow up. Referring doctors don't always tell us what's happening, but half the times, even if it's one third of the times, knowing the final outcome will always make a difference to our understanding of disease processes. I mean, how else would I have known that this is a titin or a TTN related genetic dilated cardiomyopathy unless we'd made the effort to follow up, or if the patient had come for a follow up MR and then we'd seen the history, etc. That also does happen. So that was it. This is the new classroom that I've started based on this elaborate colored flow chart, But do go through the introductory curriculum video. I mean, then if you're interested, maybe it'll be worth it for you. That's the WhatsApp channel. Thank you so much for viewing this.